My name is Carmelisa Mindrum. I'm a second-year mental health counseling student in the master's program at University of Cincinnati. And this is my capstone project for my fellowship program looking at treating chronically suicidal clients across disciplines. So I have three main objectives for this project. So the overarching one is that I plan to create an informational website for staff and interns at my internship site to learn more about working with chronically suicidal clients. I forgot to mention at my internship site, I provide individual and group counseling, and the population served at our site are underserved adults with severe mental illness or substance use disorders. So yeah, the overarching purpose is to create this website. And to kind of help create this website, I'll distribute a pre-test survey, which will kind of help me get an idea of how knowledgeable the people who take my survey are about working with chronically suicidal clients, how comfortable, and whatnot. So for those who complete the pre-test survey, they will be distributed a link to my finalized website, because I will finalize the website upon looking at those results to see if there are specific subject areas I should emphasize. And then for those that review the website in full, I will send them a link to a post-test survey, which will essentially be identical to the pre-test survey. And so in order to see if knowledge has changed, it's a measure of, okay, have the number of correctly answered questions increased or decreased or stayed the same? And then with level of comfort, okay, so has the level of comfort experienced by or that someone feels with working with a chronically suicidal client changed after they have reviewed my website? And there's an interdisciplinary focus with this project. So one part of it is that I will be administering this survey or sending this survey and providing the link to my website to people of multiple roles at my agency. So that includes counselors and social workers, other direct service staff such as job coaches, job developers, educational support staff such as trainers at our gym, kitchen management and maintenance, administration. And then the second piece is that I will interview those who work in social work or medication management, nurse practitioners, about their unique experience and perspectives in working with chronically suicidal clients. So the theoretical framework, the foundation of my project, is the idea of the three-step theory created by Chronically and May. And so this theory posits that the manifestation of suicidal ideation and then the transition from ideation to suicide attempts are two separate processes and based on separate explanations. That should be kept in mind. That should be kept in mind when assessing for risk and reassessing for risk. So first of all, the first hypothesis of this theory is that suicidal ideation occurs when someone's experiencing both hopelessness and pain, which is usually psychological pain or also referred to as psychic pain. 2, for those suffering from this pain and hopelessness, is found that connectedness to others is probably a protective factor against escalation of this ideation to a suicide attempt. And 3rd, the theory views that escalation from an ideation to an attempt is fueled by, quote, dispositional, acquired, and practical contributors to the capacity to attempt suicide. And basically what this means is fueled by personal characteristics, learned abilities, and other factors that can increase one's capability of making an attempt. So next I'm going to go through the levels of risk across two different categories. So I will go through acute, the acute risk category, and the chronic risk category. Within each category, there are 3 stratifications or 3 levels. So the levels of risk in the acute category will start with low acute. With low acute, there's no current intent or plan, specific plan that is, no preparatory behaviors, and the client's social support system is confident that they can stay safe. So this isn't just the patient saying, yeah, I can keep myself safe, I'll follow the safety plan or the crisis plan. No, it's their family and their friends also saying, yeah, I know for sure this person can keep themselves safe. Intermediate acute. It's a little bit different. So, suicidal ideation, but it may or may not lack intent. There are some protective factors that can be identified with these individuals, though. So, individuals in intermediate acute risk, they might be able to identify reasons for living or perceive themselves as able to stay safe on their own. And most likely, with people in this amount of risk, there are no preparatory behaviors. With high acute, there is suicidal ideation and intent and a lack of ability to remain safe without extra support. Risk factors associated with the high acute risk include a recent attempt, preparatory behaviors, acute stressors such as work, relationships, money, and access to means. So here are the levels of risk with the chronic category. Low chronic may have mental health or substance use diagnoses, identifiable strengths and resources, and usually able to tolerate stress without having SI, or suicidal ideation. So there may or may not be diagnoses of these sort. Identifiable strengths and resources means we can see some protective factors. So this person's got a solid support system. They have some good coping skills. Strengths. They have some personal characteristics that allow them to handle distress in a positive way, or have a high distress tolerance. Intermediate chronic. So here, these are individuals that definitely have a chronic or severe psychiatric disorder, substance use, chronic medical disorder, or chronic pain. However, you can still see protective factors in their lives, such as their own ability to cope, and they can identify reasons for living. Finally, there's high chronic. And high chronic is the most intense and most severe. So with this, these are clients or patients that have chronic suicidal ideation. And this involves the criteria that I mentioned before, diagnosis-wise, about certainly having a psychiatric or substance use disorder or some chronic physical ailment or chronic pain. There's also fewer protective factors. So the ones I mentioned with intermediate chronic may not be there. So there might not be positive coping skills or that many coping skills for that person in their toolbox. And they might not be able to really identify reasons for living. And also, too, there could be instability in their relationships or their living situation, such as their finances or their housing. So here's a list of mental and physical health conditions associated with chronic suicidal ideation. This is not an extensive list. There are plentiful amount of conditions and symptoms and factors that can contribute to one's experience with suicidal ideation or chronic suicidal ideation. So these are just among some of the few. So I found research mentioning chronic pain and also specifically fibromyalgia as well. Chronic illnesses like pulmonary artery disease, traumatic brain injury, post-traumatic stress disorder, developmental trauma, these three personality disorders in specific, borderline, dependent, and narcissistic, bipolar disorder, depression, schizophrenia, severe anxiety, so such as in the case of panic disorder, substance use disorders, eating disorders, and cognitive disorders. And these are the most commonly used interventions that I've found in the literature. So that'd be dialectical behavior therapy, cognitive behavioral therapy, psychodynamic, problem-solving therapy, mentalization-based treatment, and transference-focused psychotherapy. All right. So here I'm going to discuss some key takeaways from my interviews, one with a social worker at my internship site and the other with a nurse practitioner. So the social worker interviewed, her name is Mary Lynn, and she said that when conducting a risk assessment, it's most important to ask if they've had a previous suicide attempt. She said also, too, it's important to take a look at whether the client is having their medications managed properly and are they in the appropriate level of care. Say they're in an outpatient level of care. Well, should they be in something more intensive? Like, should they be an outpatient or should they be in partial hospitalization? So just making sure that you're aware of that. Also, look at family history of suicide attempts and a person's background of abuse or trauma. If there's a background of abuse or trauma, notably verbal or emotional abuse, it's likely that an individual may have internalized some negative messages that they were told growing up, and these negative messages can, in turn, contribute to suicidal ideation and chronic suicidal ideation, potentially. She also said it's important to encourage positive coping. Mary, who's a nurse practitioner I talked to, she said it's super, super important to assess a client for their access to means. This is especially if they say that they have suicidal ideation or homicidal ideation, but she likes to ask this during intakes in general because she says that this is one of the main things that you want to make sure you have a good call on right away. What does this person have access to, and what can be done to restrict their access in the event of a crisis, even if they're not currently in one. She also said it's important to know that providers' perceptions of suicidality can be biased, whether that be by one's own personal emotions or their own previous experiences. And she said it's important to instill hope and provide support to people with chronic suicidal ideation. And when you're talking with them, to refer to the future. So, say you're planning to see them for an appointment next week. Say, I'll see you next Monday, okay? Something like that. Gets them thinking about the future too. Alright, preliminary findings. So, these are preliminary findings from the survey responses I've collected thus far from my pre-test survey. So, with the pre-test and the post-test will have this as well. There are 5 questions, not listed on here, but that ask participants about their role at the agency, how long they've worked there, their level of comfort in working with someone with chronic suicidal ideation, whether or not they've had experience, and what kind of interventions they've used. The other 5 questions are this knowledge check. And in the parentheses below each question are the answer choices that I provided on the survey. So 1, what is not considered a risk factor for chronic suicidal ideation? 2, true or false? Only clients with borderline personality disorder experience chronic suicidal ideation. 3, if client has suicidal ideation but also the ability to maintain safety independently, they are at what risk? 4, which of these interventions has been found to be beneficial for chronic SI? Or chronic suicidal ideation. And 5, what is the feature of borderline personality disorder most closely associated with chronic suicidal ideation? And this is kind of a tricky question because it's essentially saying what is the feature of borderline personality disorder that's a common thread among individuals, all individuals with different conditions, different symptoms who experience chronic suicidal ideation. So here are some basic stats. So I had 25 respondents whose responses I collected. The average length of time that anyone worked there was a little bit over 3 years. I had the distribution of number of participants per role in the agency to the right, multiple roles. Keep in mind, all 3 of them are counselors or social workers, but they also have additional roles at the agency as well. And out of the 25 participants who completed the survey, 5 of them answered all 5 knowledge check questions correctly. All right, so one of the things I was measuring was experience working with chronically suicidal clients. And so this is just looking at experience or no experience across the different roles at the agency. And as you can see, counseling and social work have the most experience. Again, keeping in mind that multiple roles includes counselors and social workers. And then this here is looking at comfort, level of comfort working with chronically suicidal clients. Are they uncomfortable, neutral or not sure, or comfortable? And so it was interesting with this one because with the counseling and the social work, there was a high number that said that they were neutral, not sure, or uncomfortable. But luckily there were still some who said that they were comfortable. And it's the hope with this project to increase that level of comfort. And finally, these are some of the interventions that were mentioned. So the CBT, DBT, existential, and psychodynamic therapies were all options mentioned to the participants from what to identify what they currently use. Other includes interventions such as person-centered, Adlerian, reality therapy, mindfulness, and creative therapy. So these are my findings thus far, and I am currently in the process of working on my website.